Good afternoon and welcome. I think we'll get started here. Hopefully this will be lively enough that folks aren't falling asleep after their lunch lull. So this is the healthcare panel, and I think I phrased it something like Medicare for all, how Oregon makes its way essentially to single payer. So we'll be talking about a lot of these topics. We'll kick it off here by letting these esteemed panelists introduce themselves. But first off, my name is Andrea Salinas. I'm the House District 38 representative. Thank you for some of my constituents for being here. I also serve on the House Healthcare Committee. I am the chair of the House Healthcare Committee. I serve on the Public Employee Benefits Board now. I also serve on the Subcommittee for Behavioral Health, which is newly formed. And I also serve on the Subcommittee for Ways and Means, Human Services, as well as the Energy and Environment Committee and the Willamette Falls Task Force and some other things. But those are things that are pertinent to healthcare. So I have an interest in this topic because after I was elected to, or actually appointed to the seat I serve now, I was asked to lead a universal access to care work group. And so I have really been focused on what single care looks like for the last several years. And it even goes back a couple of years before that when I was doing some advocacy work. But right now I just would like to let my esteemed colleagues here introduce themselves and tell you why they are interested in this topic. And then we'll get into more further discussion. And we will leave plenty of time for questions so everybody can really dig their teeth into this topic.
Alright, so my name is Rob Nosse. I use he, him, his pronouns, and I am a state representative for Inner Southeast and a little sliver of Northeast Portland, House District 42. And I am representing Salinas' wingman for the Democrats on the Healthcare Committee. I'm the vice chair, where I've been the vice chair of that committee now for 3 terms. And I'm also I had the privilege of being the Ways and Means Subcommittee Co-Chair for Human Services, which funds a lot of the healthcare programs in this state. And then I'm also on the Rules Committee, which deals with, like, we want to say something nice about Eric Hunter and pass a resolution, we do that. It deals with election law. And then when we can't pass a bill as Democrats in the appropriate policy committee, we send it to Rules and then pass it there. So when I'm not doing this, I work at the Oregon Nurses Association, where I've been a labor rep since 2004, and I've worked for other unions before that. And then I got into politics via the Oregon Student Association when I was a young person at college. That's a little bit about me. We'll let you go last. We'll go to Glendora.
Oh, okay. Hello everyone, my name is Glendora Claybrooks, and how I got into this. I am a healthcare advocate for patients, and I'm also a community activist and a healthcare consumer. I am the population for which Oregon is trying to help improve access and quality healthcare. So I will be talking today about what are some of the ways that we can help the state of Oregon attain its AAA goal, and that is better healthcare, expanded healthcare, quality healthcare, and cost reduction.
Good afternoon. My name is Eric Hunter, he, him, his pronouns. And I recognize that I was asked on this August panel probably because I'm the CEO of CareOregon. We're celebrating our 25th anniversary of serving OHP members here in Oregon. We currently serve more of them than anyone else. About 250,000 OHP members are cared for by CareOregon. We also have the largest population of dual eligible Medicaid and Medicare populations in the state that we care for, 13,000 of those. So we've got a bit of an impact in the healthcare of our fellow Oregonians. My personal story really is, as a Democrat activist on American Salinas, goes back to 1976, when I was the only 5th grader in my class to say, no, Jimmy Carter should be president, not Gerald Ford. I agree for that. It was an Army-based town. But that's where it started, and since then I've been involved in politics and campaign, college Democrats, young Democrats. Ended up working for the governor of Oklahoma in the early 90s when he actually implemented Medicaid managed care for Oklahoma. So that's how I got into this side of the business. Went into the agency that created Medicaid managed care in Oklahoma when I stood it up from the state side, and then a private company hired me. From there, I subsequently worked in Medicaid, Medicare, commercial insurance, behavioral health insurance in about a dozen states. So I've got a bit of a, I think, varied sense of what folks are doing, where, how the systems interact with each other, Medicaid, Medicare, and I'm excited to be a part of this conversation because, you know, I'm one of the people that, you know, we are an insurance company, so when I hear Leonard say, hey, we would have all insurance companies, and just, I've got a problem with that. But it's not because it's, you know, hey, we don't want to change the system, it's because we want to do it right. We want to make sure we're reasonable and rational about how we serve the populations that we're entrusted to serve. We don't leave folks their own design. So I'm really looking forward to having this conversation and see how it goes.
There's some implementation in the way you're on this side.
That's right, that's right. No, I'm glad, and I love that I have my Healthcare for All Oregon advocate here, and then somebody who may defend insurance over here. So I think I hopefully.
Nonprofit.
That's right, nonprofit insurance.
Big difference.
So I'm just gonna kind of set the foundation for how I see, the lay of the land right now, both at the federal level and then what we are doing at the state level, and then kind of kick it off to these folks to talk about some things that we've done over the past few years. I think we've done some really good work since 2017, probably before that as well, but that's kind of been the time that I've been working on this, and then maybe some innovative ideas to move us forward. So when the Kaiser Family Foundation in 2017 asked people how they felt about the term single payer health, 48% gave it a thumbs up. That tells me we're doing some good work. We're at 40%. At the same time, when Kaiser asked them how they felt about Medicare for all, support rose to 62%. What this tells me is that single payer sounds uncertain. It's not the known brand that Medicare is, and there aren't really any definitions around it. We don't know what the benefits could be, and we don't know what the cost would be until someone defines that single payer program. But we do know what Medicare looks like, and we can take that leap of faith that if it works for our nation's aging populations, then it should likely work for all Americans. Hence, right now we are having a debate on the national stage, which I'm really excited about actually, with our Democratic presidential primary candidates around Medicare for all. But I still think it's a term of art, and we have to figure out and try to dissect it and what does it really mean. So, and I just will right now just use one example and one bill. Representative or Congresswoman Jaya Pell's bill. She's from Washington, and she explained her Medicare for All bill, HR 1384, this way. We mean a complete transformation of our healthcare system, and we mean a system where there are no private insurance companies that provide these core benefits. We mean universal care. Everybody in, nobody out. The bill would sunset Medicare and Medicaid, transitioning their enrollees into the new universal plan. It would, however, allow two existing federal health systems to continue to operate as they do now, the Veterans Affairs Health System and the Indian Health Services System. It would bar employers from offering separate plans that compete with this new government-run option. And this is essentially a single payer proposal. It would create a universal health care program that covers all American residents in one government-run health plan with robust benefits that include dental and vision. And when asked about how the pay for, they call in Congress, how do you pay for this plan? The answer was, well, Congress doesn't have to find a pay for in their bills. And she's right, they don't. They can do budget reconciliations. I know, they have that privilege. I don't. They don't. Welcome to the state. So it's, you know, they're on a different scale. They get to be really aspirational. That's why I'm excited about this, because I think this conversation needs to be had. We've come so far about not even wanting to talk about single payer, and now we can all shout it from the rooftops. But for those of you who maybe attended the breakfast this morning, you heard from Attorney General Rosenblum and Commissioner Roy Stegman that much of their work right now is on trying to stay one step ahead of our current administration. Everything from gag clauses limiting our entitlement funding for reproductive health care, to the public charge and the census, which puts Oregonians at fear of showing up and seeking those access to those services. And the state legislature has been doing much of the same, especially in terms of healthcare. We've tried to stay one step ahead of the feds in forging our own path, because even when we take back the White House in 2020, we still need to flip 4 U.S. Senate seats. So it's uncertain what our landscape really is going to look like as we head into 2020. After I was appointed in 2017, I mentioned this earlier, I was tasked with leading Universal Access to Healthcare Work Group. We spent 11 months evaluating studies, learning about what other countries and states are doing to address universal access to care, and asking for additional data from OHA on the current status of Oregon's healthcare system and the uninsured. Recognizing that we've made tremendous progress since enactment of the Affordable Care Act, expanding Medicaid and expanding healthcare to all Oregon children under Cover All Kids, we still have a population of about 245,000 Oregonians. That's the last 6%, who are either under or uninsured due to reasons that range from losing their Oregon health plan coverage, unaffordable premiums, loss of a job, or loss of employer coverage. And yes, there is still a small percent of folks who just simply aren't interested in health insurance. And during our discussions on universal access to care, we ran across some core principles that I think we all believed in, and CareOregon was present, Healthcare for All Oregon was present. The goal should be better healthcare outcomes to more people for less money, with a comprehensive benefit package that includes vision, dental, and mental and behavioral health care. In other words, I summed it up, all services to all people in all corners of our state. We looked at the effect on provider payments, maintaining and bolstering access to providers in rural and frontier areas. What would a universal access to care system look like? And what are our networks going to look like? Cost shifting and risk pools were also some of the key topics discussed as we evaluated different models and how Oregon really might start to march towards single payer. Oregon receives more than 50% of its current healthcare funding from federal programs like Medicaid and Medicare. We also face the hurdle of the current employer-sponsored healthcare coverage and the ERISA laws that govern those plans. And as I mentioned earlier, we don't have the luxury of not balancing our state budget. And we typically are asked, when we're asked to pass big pieces of legislation, we are asked to get it as what they call revenue neutral as possible. So the state would need to capture the current taxes many Oregonians pay in terms of healthcare and their health insurance, as well as the taxes their employers pay for their healthcare, in order to pay for a new system to produce a budget neutral impact on consumers. Oregon would also need waivers from the federal government to accomplish this. And getting these waivers is highly unlikely under our current administration. But this doesn't mean that we can't make progress toward a single payer system. There are several bills that the legislature has passed since 2017 that are moving us toward universal access to care. And I'm hoping that the experts that we have here today will all be able to talk about some of these accomplishments. I know I work personally on the Reproductive Health Equity Act, which expands coverage on reproductive health care for all Oregonians, and this is something I'm quite proud of. But we need to prepare for a system that truly is more equitable with quality access to healthcare for all Oregonians. And with that, I think I will just kick it off to Representative Nosse and let him talk a little bit about where he thinks things are headed.
Okay. Any of you subscribe to the Atlantic? A few of you. Okay, good. I recently had a long plane ride where I got caught up on the July issue. And the article that I'm sort of kicking this off with was a thing called Worst Patient. I just got done from this plane ride. Worst Patients in the World. And let me just sort of sum it up. I'm sort of the eat your vegetables part of this presentation. So, in the United States, the article points out that we as a country lack community-wide norms as a nation around healthcare and health. We talk a lot about cost, but when you survey about it, insurance and how we pay for healthcare actually masks a a lot of the cost for many of us. So some entities surveyed 10,000 patients, and 31% of those 10,000 patients said they were concerned about cost. 85% of those patients said they were concerned about the compassion that their provider might show them when they went to seek care. I thought that was interesting, so did the article. Elsewhere in the world, where they have single-payer style systems, if it's expensive to do and not proven to be much better than something they've already been doing that works pretty well, you don't get to have it, just as a matter of course. And if we try to do that here, like if we try to deny you some new shiny procedure or pharmaceutical, many of us raise holy hell with our insurance company about how dare they not allow us to have something that is available in theory. We are over-tested and over-treated, according to this article that I read. And then we don't stick to our routines. And then lastly, we act like death is not a thing. We throw everything at us, ourselves, at the end of life to prolong it just a little bit longer. So that was really like the downer part of this whole thing, right? So I want to talk to you about some of the like eat your vegetables things that the legislature is doing or has tried to do, because if we're going to have a single payer system, then part of what we have to address is that it's actually expensive to do this, and we have to have cost control mechanisms, quality control mechanisms of some kind in place so that we can balance making this a universal system while still actually affording it and operating it. So for example, probably many of you know that if you have a company-based insurance plan where you work, or you're getting an insurance plan on the exchange, you know, those plans often have a good year when their rate increase, when their rate of cost growth is like 7 or 8%. Often it's been higher in my life when I'm collectively bargaining insurance for nurses in hospitals. And so one of the things that we've been doing as a cost containment measure since 2017, and since before, is we hold the public employee benefit system and the teachers benefit system that we operate as a state to a 3.4% growth rate. And I imagine Eric will talk a little bit about how that is very difficult to actually adhere to. Another thing we did in 2017 around cost is that PEB and OEB are contracting with hospitals and telling them in the state, we are only going to pay when one of our employees, as a state employee, one of our members shows up to your hospital, we're only going to pay the charge at 200% of what it costs Medicare to do it, or what they charge. So we'll only pay double what Medicare said. Now that seems like, wow, you're willing to pay double, but like that is actually something that the Hospital Association is quite grouchy about in terms of the state of Oregon controlling the costs for their employees by pegging what we would charge for an emergency appendectomy or a normal vaginal birth delivery to 200% of the Medicare rate. In 2017, I tried to pass House Bill 2387. This was a hazing experience that Representative Greenman set up for me in 2015 when I was a freshman legislator and didn't know any better. And the goal of the bill was to try to get at our favorite boogeyman in the policy space for healthcare, which is the pharmaceutical industry and what it charges all of us and our health insurance plans for drugs. Some of you may know this, but in the United States, right now, roughly 1% of the drugs that are prescribed are 50% of the cost in the pharmacy cost space for an insurance plan. Think about that. That's incredible. And so my bill, which did not pass because it was too aggressive, okay, House Bill 2387 would have capped co-pays on your prescriptions so that consumers would have a reasonable expectation about what their out-of-pocket costs would be. And in exchange for doing that, we were going to mandate that pharmaceutical companies had to explain why they were raising their prices when they did it more than 10%. And if they raised it more than what that average was in other, as we say, developed countries, they were going to rebate to insurance plans the difference to help them have manageable costs for drugs for their members, which you can see now why that did not pass, right? Okay, so we did pass. We also looked at hospital costs, back to that. We tried to look, so one state in the United States, Maryland, does not have a system of billing for hospital patients like we experience everywhere else in the country, where Medicare bills at one rate for an emergency appendectomy, Medicaid bills at another, and then your commercial insurance bills and gets paid at another for the same thing. In Maryland, if you go to the hospital for that procedure, whether you're on Medicaid, Medicare, or you're on commercial insurance, that hospital is basically going to bill that insurance plan at the same rate. So only Maryland gets to do that, and that is a whole other workshop that we can have another time explaining why. And so since only Maryland can do it that way, we have embarked on another approach, an approach that the state of Massachusetts is taking, where we are going to try to set up, and this is something we passed in 2019, I call it a tuition cap for healthcare expenditures across all the sectors in the state of Oregon, because I think it's the easiest way to understand it. Most of us understand if we're capping tuition at a state university, we're only going to let it go up 5%. That's the cap. And so with this bill, which we have passed it in theory, but we haven't passed anything that actually implements it yet, Senate Bill 889, we will set some sort of cap on the rate of growth or the rate of expenditure growth across all the sectors in healthcare. So ideally, we're going to get drugs in there, hospitals, providers, insurance plans, and say to all of them, you can only allow your costs to go up by a certain amount. We probably will peg it at 3.4% because that's what we've been doing for all the other programs that we operate that are state controlled. And so that's it. And if you try to go over that, there'll be penalties. As a way to say, we can't sustain this anymore. These annual 8, 9, 12% increases in costs are just unsustainable. So then the last thing I would mention under eating your vegetables on the journey to single payer is we did get one bill in the pharmaceutical space passed in 2018. We were the second state in the country to do it after California accomplished it. And we are now in the process of implementing drug transparency in the state of Oregon, House Bill 4005. And that was my bill. And it was a good bill. I mean, you think, like, gosh, we had to pass a law just to get people to explain why they're raising their price. I mean, think about that for a second.
Yeah.
Right? But we believe that in the laws being implemented, the first wave of that has come through where insurance plans are revealing what their most expensive medications are and how often they prescribe them to give us some context. But then drug manufacturers are required now to report into the Department of Consumer Business Services, and they'll be putting this up on a website at some point very soon, saying, okay, here's why we increased the price on some medication, and here's our justification for it, and then we're going to see what we learn.
And just real quick, because we're all activists, if you know that your own prescription drug prices are going up more than 10%, there should be a card at your local pharmacy that we've just now implemented. I'm so excited about this as well because it actually gives consumers a tool of their own. And there's a phone number and a website on there. Yeah, so call DCBS. They want to hear from consumers directly. So that was part of HB 4000.
I just gotten that last week when my prescription doubled.
You still can. So go to the DCBS website and there should be a phone number. Just a Department of Consumer and Business Services or the IRS, or excuse me, the Insurance Commissioner. Yeah.
I'll announce it.
Yeah. Go on, Glendora.
Okay, excuse me. I'm not as experienced as these gentlemen are around the table, so bear with me if I err and charge it to my head, not my heart. I just want to say I have a script because I'm so impacted by our current medical healthcare system until I have 50 things running through my head at one time. So I'm just going to start by saying I'm here today speaking on behalf of the patients because I am a direct product of the disintegrating design healthcare system that for centuries have benefited the 1% of the dominant culture whose primary focus has been and is still on profit over people. Given the many fragmented components in our healthcare delivery system requires a generalist expert. I do consider myself an expert. I have 45 years in the healthcare arena, working within primary healthcare and every other sector, specialist healthcare organizations that you have perhaps seen, such as cardiologists, gastroenterologists, those kinds of specialists, right? So, and today, I am no longer working in that environment, but even I get confused at how to go about to make a simple appointment, because I have to call so many departments in order to get access to in order to get a good understanding of what I need to do in order to comply with my treatment regimen. So if I, with all of this knowledge in the healthcare arena, am having problems, just imagine, I can imagine how you guys are faring, trying to get from one department to another, or one treatment to the other. So it's a complex process. So in navigating, as a patient advocate, I have to know about what important questions to ask to help inform the patients about what's available to help meet their needs and to help them make choices. For example, having knowledge about the different types of public and private health insurance plans, including the managed care, CCOs, PPOs, MCOs, and their trends, or the overall healthcare industry, period. I need to know about the organizational and government administrative practices, the procedures and policies. I need to know about where to obtain this information. To understand all this, I must be familiar with, as I said before, specialty healthcare providers such as pediatrics. I need to know about what is beneficial to the elder care, to the physically disabled, the mental illness, the chronic diseases, death and dying, in order to be able to advise the families with choosing the best policies available. This in and of itself, as I've said before, is a challenging and disastrous feat. It leads to unnecessary preventable stress, which exacerbates patients' health conditions, no matter the type or diagnosed illness. Stress even prevents expedited healing due to an injurious nature, such as a fall. It's not just one population, but all of us who is at risk for poor health outcomes, poor quality of care, and out-of-pocket expense. The at-risk populations include everyone, the public at large, the elderly, the physically, behaviorally, developmentally, underemployed and unemployed children, the average healthcare consumer. We are at risk of not having our health needs met because of our healthcare system's practices, design, its policies, reimbursements, and the charges for adequate, quality, and appropriate healthcare services. As a lifetime healthcare professional, consumer, community advocate, and activist advocating for social justice, I am focused on the holistic approach of how healthcare services plans are designed, implemented, evaluated, accessed, distributed, delivered, and its healthcare outcomes or benefits thereof for all of Ghanaians. So, what factors should and must be considered in the healthcare delivery system when developing a viable single-payer healthcare plan fitting for all Ghanaians? Well, the factors must include both inpatient and outpatient services, including rehabilitation, skilled nursing facilities, home health, hospice services, Specifically, social determinants of health, which includes education, housing, those kinds of areas, and the quality of care, not to mention the affordability of it, and the appropriateness that includes timely care. These considerations are important to an individual's overall health and healthcare services. These provisions are not sufficient to address the ongoing disparities in poor health outcomes, even when these measures are accounted for, such as if you do get help with your housing or with your education, you still are at risk of receiving quality care. So, what has been left out of the policy developing process heretofore that has contributed to health disparities, increased healthcare costs, inadequate or poor health quality services, and appropriate culturally focused services, brings me to the private sector. I believe that we as healthcare professionals, providers, advocates, and activists have failed to accept and admit that the private sector, business and insurance markets, whether for-profit or not-for-profit, have not been successful in providing equality, equity, quality, and affordable, accessible, appropriate, or timely healthcare services for its workforce populations. What these entities have been successful at is thwarting people's choices in healthcare services based on what health condition is covered and not covered, the cost, the premiums, and the profits. Thus, these allowed practices only serve to promote and sustain socially divisive conditions such as classism, racism, and sexism, all of which encompass discriminatory practices and policies that continuously result in poor health outcomes for those underemployed and unemployed populations, especially among Black African Americans. I won't give you any statistics because if you know anything about healthcare and how it has not addressed the needs of the public, you also know that Black African Americans rate highest among that population when compared to all other populations. Yet, we continue to apply the rule of insanity, expecting a change in preventative care and health outcomes. This is unconscionable. After all these years, we continue to promote myopic measures in how we define, distribute, disseminate, and reimburse for healthcare services based on this fragmented healthcare system of inadequate quality services that contribute to millions of people dying and suffering at disproportionate rates, prematurely and needlessly. I have more time? Okay. So, with regard to the public sector, that brings me to talk about the healthcare for all, Medicare for all, which is good and noble, and all the things that we have accomplished here today is a step forward. However, we're going to have to reevaluate the people who are sitting at the table and making the decisions for those populations who are oppressed and suppressed and are not represented. At the end of the day, when we go out and we talk to our communities and we learn from them what their needs are and what they think we should do, what happens? The same old happens. Nothing happens. We are still at risk of suffering and dying prematurely from diabetes and heart disease and such. So we have to ensure as a healthcare consumer, we must get involved and engage and have a conversation with those who are sitting at the table making the final decisions. After people like me at the community level share what our needs are and how we believe what should be done in order to meet those needs, we are not oftentimes sitting at the final decision-making table. So this is where we have to be. So we have to learn how to educate the public in order to get them to be active in their own health care. And to do this, they need to know what steps they need to take to ensure that they are doing a responsible deed in order to keep their health status in a good, keep their health status right, exactly, thank you. So, in conclusion, it is not sufficient or sustainable to narrow our focus on just the social determinants of health, to provide adequate services focusing on how government health policies and laws and states and unregulated corporate policies influence our social economics, including wages and our rents. These issues negatively impact our ability to access adequate services. So, in conclusion, whether we call this single-payer health care Medicare for all or health care for all, when determining how we get to fewer payers or a single-payer system, we must consider an approach that is bold, perceived to be high risk, and are different to reflect unforeseen new and minority leadership, and that would dismantle the current private, nonprofit coordinated care organizations with no proven track record in the reduction of poor health outcomes among disenfranchised communities. Thank you.
Thank you, Andrea. I think you set up the problem very well.
Okay, good luck. I don't know where to, I have stuff written down that I think that, I don't know that I consider myself an activist. I think I have a vision for where I want healthcare to be, and I'm more of a pragmatist, but like I said, I've been a lot of places, seen a lot of things in action, in reality. Vision is great, it's gotta be where you want to go, but how do you get there, and what's the speed, what are the trade-offs of doing those things, make sure those are top of mind. But as Rob mentioned, 3.4% is what the CCOs are held accountable to for year-to-year increases. But you think, hey, 3.4%, if I had that in salary raise every year, that'd be great. Except that the trend of what I pay out is at 7 and 8% a year. So something eventually has to give, particularly when the CCO model, which I love, is why I came to Oregon. I was in Massachusetts before here, and this was the only place that I found more progressive than Massachusetts. So I came here, but that model asks us to do a lot above and beyond basic health care. So we're not tasked with just paying claims and big commercial companies denying claims. We're tasked with engaging in social determinants, engaging the community, having coordination with public health, with education, with law enforcement. That's a part of the entirety of the package that we're asked to provide. So there's a lot to it, but I think the CCO model is really a great first step in getting us where I think we all want to go. I think the VAC survey showed that single payer scored a certain number, and then Medicare higher. Even Congressman Jayapal has a different version of what Medicare is than sort of what Medicare really is. So Medicare is not a system of no insurance companies and everybody gets whatever they want. That's not Medicare today. As I said, I manage 13,000 Medicare people, and we I think do a good job. We have expanded benefits for them that folks on fee-for-service Medicare don't have. We have coordination of care benefits that those folks don't have. We have proactive engagement of them on their health needs. We have health resilience coordinators. We have specialists in the clinics. So I think there's a role for managed care and coordinated care in Medicare, but that's not what folks are talking about. So when I hear about Medicare for all, I think that it's a great concept. If it really at the end of the day is about getting the universal access, safe and affordable access to everyone, no matter their circumstances, and how we get there. You know, I think we can have that battle, but let's at least get everybody agreeing that healthcare is a basic human right that everybody has, and then we figure out how do we make that happen in sort of the context of an industry that is, you know, the vast majority of government spending, at least in the entitlements space, and then overall economy impact. Some of these changes would be great, but you have to see where it fall out. And I think when I think of CCOs in particular, the Affordable Care Act, you know, was great, but Oregon started this work before that. You know, Governor Kitzhaber and a lot of really amazing visionary people said, how do we change the dynamic overall? How do we go from systems where I was used to working, even 2 years stint with a big, you know, publicly traded company that I still sort of, you know, probably shouldn't have been, I'm a public hospital kind of guy, but you know, we try to take care of folks at the nonprofit level without injecting stock price into this business and worrying about shareholders, and you know, I think that makes Medicaid more difficult to manage when you have those considerations. I think the CCO's original intended didn't necessarily have that restriction. It was an experiment. We had to see what happened, and we weren't sure who was going to have to play. But I think that the concept, though, of person-centered, integrated care that has to work with the communities, you know, as you mentioned, so that it's not an insurance company or me and my staff sitting on the 315 Fifth Avenue in Portland saying, you know, we're going to do this no matter what it means to the consumers. We don't care what happens to this constituency or those members or what the data is. You know, we have to engage. We want to engage. I think the model asks for that and demands that, and I appreciate that. You know, but the system also created the herd and the line. So even Oregon, progressive, aggressive Oregon said everyone can't have everything. And that's really going to be the challenge here, is how do we balance the desire to make sure that we meet the needs of people where they are, those things that they know they need, that they believe they need, proactively and after the fact. How do we balance that with the realities of a world in which the state has to balance its budget? You know, as it stands right now, we think we're okay for a year, but we still need this cigarette tax to make the Medicaid budget balance. You know, so the idea that we just sort of throw the doors open, that scares me a little bit. And then when you think about nationalizing Medicaid and Medicare totally, think about the current environment in DC, and the current administration. What if they had the ability to alter all Medicaid and all Medicare by administrative fiat? You know, I've worked in states, like I said, Maryland, Massachusetts, Illinois, Oregon, which were looking out for people no matter what. We're going to bend over backwards to serve people. I've also worked in Oklahoma, South Carolina, and Texas, where there's not the same commitment. And so that, again, those things have to be considered as we're having this conversation. But at the end of the day,
scared everybody.
but that's why I think that Oregon can be an example of what to do maybe a little bit differently. That we, you know, again, if the ultimate goal is to get to safe, affordable, universal access to health care, the model that was envisioned here, you know, I think may be the best bet. You know, the CCOs were not meant to always be just Medicaid. It was meant to be the start of a conversation. It was meant to potentially, you know, bring Heaven OEB into it and expand the payer pool, you know, greater leverage on negotiating if you're going to go to drug crisis, those kind of things, greater leverage on hospitals and providers, not just to hold them down, but to say, you know, if we're going to sort of merge those systems, then maybe we sort of manage and average the payment rates like they did in Maryland, so that we don't have the issue which we have right now, is that if you're on Medicaid, there are a lot of providers who won't see you because we don't pay enough. If you're paying out of pocket, anybody will see you. If you have commercial, most people will see you. If you have Medicare, a lot will see you. There shouldn't be that, you know, that's where the equity comes in, when people are given different access to different healthcare at different levels based on how much money they have. We can do away with that. You know, so if we say, again, it's happening, they go to Germany at the national level, they do it in Maryland, you know, no matter what the payer source is, you get paid the same amount. And there's no incentive to not see Medicaid folks. There's no incentive to prioritize commercial. I mean, those are the kind of things that through Oregon, if we can get at least that far, I think that will show the rest of the country this is doable. But you have to, I mean, reality sets in again, you know, there's been talk about that for a while, and I I don't know how much, since he said many, representatives, how much success they think we would have if we pushed to merge PEB and OEB with the OHP program. I think it would be a heck of a battle, but we have to think about it. If our ultimate vision is to be universal access, healthcare for all, Medicare for all, then we have to at least first be able to bite that bullet ourselves and say, let's at least take a step and show that that's doable. I think Oregon can. I think it's got the leadership, it's got the will to do it. But I think that's where I think the battle will start. It'll be an example of the rest of the country. And hopefully let states do what they need to do. Let the federal government set some minimum threshold of benefits, the essential benefits, so you don't have any more of these junk, bogus plans out there that are taking people's money for nothing. But after that, let the states be the experimenters and do those things that are great. And at least Oregon, we'll take care of our people, and then we'll show an example for the rest of the country and say, here's how your state can take care of yours as well.
Thank you to all three of you. So you all touched on a few things that I want to come back to, and then we'll open it up for questions. I see we're almost, about 20 minutes out. So I know, this went fast. So a couple of things, I think Glendora and Eric, you both touched on this a little bit. In terms of provider payment reform, right now, in general, we aren't paying for that person-centered integrated care that we really, I think, have as a model in the way that we should be. So for those who have the first and most frequent contact with patients, they really aren't getting paid fairly. And where we see the larger payments being made is at the top end with specialists. And those are the folks who really don't see patients as frequently. And they aren't the ones who are really managing their care and making them adhere to their treatment plans and that sort of thing. So primary care providers need to know that they can provide care in all parts of the state. It doesn't matter where, if it's rural Oregon or Portland, and that they aren't going to default on their school loans, that they've made the investment because they will get a fair shake from it. And this includes behavioral health care providers, which we really have not integrated into our system of care. We shouldn't be bifurcating these two things. My head and my mental psyche is not separate from the rest of my body. They actually influence each other. And so until we get to that place, and I do think that this is a place where the state can have some influence. And I also think, and I think Mr. Hunter mentioned this, really aligning value-based payments and making sure that the commercial market behaves more like our CCOs in terms of what we're paying for. We don't want to just pay for additional services. We want to pay for better health outcomes. And as we start to push some more of that alignment and hopefully start to see some mixing of these pools as well, because those payments and the providers will also be there. You'll have a network that actually works, and you'll have provider payments that are a larger mix. And one thing that we passed this last session, and I did this with my good friend Senator Manning there in the back, was SB 770, which will ask the legislature to really look very hard and closely at a single payer system for Oregon and what that will look like. But in the meantime, we are going to crunch some numbers on a Medicaid buy-in option. And this was something we talked about in my Universal Access to Care work group. What would it look like if folks who work for small employers, but the premiums are too high and the cost share and deductibles are too high, they simply can't afford it, or for that last, those last few who are uninsured completely, maybe because of their documentation status, what would it cost for them to buy in? And then given that we think that this is a relatively healthier population, could we use the CCO care delivery system to put those folks into it? And we know, as I said at the beginning of my statement, there are about 245,000 folks in that system. So is it possible, which is close to what the PEB and OEB population is, which is about 300,000 in that population, is there a way that we can get those folks in there, a healthier population, and get higher provider payments? So we're mixing those pools, and we can attract the providers in areas where we don't have proper networks right now. So those are some of the things that I kind of want to teach. I know, I was afraid to mention it, but I just think it's so important. I think we have providers in the room who, who could probably speak to some of this, but I also think that you may want to respond to this.
Go ahead. I'd like to speak to the the concept of really funding providers at a level that lets them do more. I think one of the best things about the CCO model is there's actually, you don't usually ask for mandates when you contract from the government, but this one we like. And it's a requirement to have a certain level of value-based payments in our contracting. So we're being told that, and I love the fact that the days of fee-for-service where you just show up and the incentive is to churn people through and see enough people to just keep sending the bills, those days are over. It never worked. It's been counterproductive for consumers. It has a wrong kind of connotation of what the priorities are for providers. So what we're doing now is these value-based payments have a number of different ways. Some of them have more risk for providers, more upside downside risk, so they've got more skin in the game for the overall health of their patients. So not just for the services, some of them for the services they provide. We've got some clinics that have an overall health benefit ratio, so the entire dollar amount, whether it's hospitals, farm behavioral health, the works. So because they're the first line of defense, that they are responsible and they've got some skin in the game for the entire spend of an individual. So that person is in their panel, it's one of their family, they're responsible for them. We work in conjunction with them and share savings, those kinds of things. I think those are the kind of things we need to move forward on, and behavioral health in particular. There are a lot of contracts that everyone, I believe, is trying to get implemented to work with providers where we actually now have embedded behavioral health in primary care clinics. And that's one of the best things. If we can get, a lot of the FQHCs do it out of necessity, they have to do everything. But if we can get other clinics to say, look, there's value in having somebody walk in the door, having a primary care visit, you identify a need for behavioral health, you send them not with a phone number and say call somebody, you send them across the hall, or somebody comes to get them. Oh, by the way, you've got a dental issue, there's a chair 3 doors down, will take you an hour. That's where you impact folks, and that's where you get sort of integrated care. And if all that is capped off with someone who's talking to them about what are their social determinants of health, what's going on in their home, are there food insecurity issues, are there housing issues, are there insecurity issues, are there isolation issues, and then again, that can be incorporated in the entire care plan, then that's what we're trying to get to. So I think that's, for me, the key to saying, if we can do more of that and be aggressive about that and share the right data with the right people to address those issues and have sort of a closed loop system even with community benefit organizations, so it's not all medicalized. We want to bill for everything, right? We want to use community partners who are dedicated to this work. How do we bring them all together to say, let's deal with a person as the whole person? I think that's the only way we're going to change the cost curve and the dynamics long term in the system.
I don't have anything to add to that point.
Lenore, do you want to say something?
I'll just say that, with all due respect, having dealt with managed care systems for over 40 years, knowing how they distribute the services as a healthcare consumer, it has been difficult trying to even get our CCOs to equally distribute their services. For example, I have a personal story to share with you. I sustained a foot injury called plantar fasciitis. I could not walk. The only way that would heal was no weight bearing. I had to quit my job. I was a single mom. I just purchased my townhome. And because the CCO that I was a member of refused to pay for the treatment that it took to expedite my healing, I lost my home. I had to quit my job, so I was dependent on the Medicaid services. And when I think of how the CCO had more patient-centered care interest at hand, perhaps I could have healed sooner. It took 7 years for that to heal. Those 7 years I was out of work. And I was devastated because I my physicians appealed to the CCO and they would not give in. They said, no, we don't cover that. And so, in the end, that turned me against CCOs and their ability to provide specialty needed care in order for a person to heal. So I just wanted to say that, and I've been quite bitter, and I would like to see our state take those funds and put it into the underemployed, unemployed citizens and train them to do the work. They have a better understanding of what it's like when you're not having your health needs met. Take those funds, train an adequate population of people, give them jobs, and let them pay into their premiums by working for the state. I think the money would be well spent.
Thank you for that, and I mean, it will be up to us too to hold CCOs accountable and to make sure that they are adhering to their mission and that, you know, truly it's not a profit-making mission and that we are serving patients. So I just want to acknowledge, I'm so flattered that Senator Merkley, our good state senator, would, I know, would sneak in and I know people can Medicare for all as well, so thank you for being here. But I know we only have about 15 minutes left, and I'd love to open it up to questions for folks. I knew there would be a ton of people, so just start here.
I'm having a semantic issue, so David Morocco, Oregon Education Association. So the semantic issue I'm having is with the term access. And what I would like you all to do, because you all use the word access, but you use it in different contexts, which it can be taken in different ways. I technically have access to a Tesla if I can pay for it, but I can't pay for it. I would like you all to agree, for the purposes of this continuing conversation, on a definition for the term access.
That's easy for me. When I talk about access, I talk about affordable quality access. And quality as a measurement of metrics that we agree on across payers. It doesn't matter. And that access means that it's affordable to the individual.
You can get it in a timely manner.
Yeah, you can get it in a timely manner.
Okay.
Does everybody agree with that? Okay.
Hi, I'm Paul Turdall, and I've done a lot of work over the last 8 or 10 years as a health advocate for consumers with autism and other disabilities, and I'm working with the DNC Disability Council's policy committee on a lot of these things. One of the concerns that I have, I think there's a whole lot of inefficiency in our current system that could be resolved with a single payer. I think that's a huge advantage. I think a concern I have as a patient advocate of, I want care, and like I have that heavy weight that you have to deal with when you're eating your vegetables, is we have this huge patchwork of laws, state insurance mandates, mental health, federal mental health parity, other kinds of things that kind of cobble together and work to get us what we need. And if we sweep all of that away to switch to something else, how do I, what can I do to make sure that I'm still going to get the care that I'm getting now, that's working for me now, that I still need?
Okay, I'll take a step at that.
Great.
So, I'll try it this way. I think if we get a Democratic Congress and a Democratic president, the way that we'll get to some sort of single payer or Medicare for all in the United States is each state will have to do it state by state, to sort of Eric's point. And my hope would be is that our Congress would sort of get out of the way. They would let us get out of ERISA or bend it or change it a little bit. Maybe block grant, that has a negative connotation, but if there's, and Maryland gets enough money. That's why Maryland does their system. They have an excellent block grant that only they are able to get, and the rest of the country can't get it. It's a long story, different workshop. But if we could get a block grant to get the Medicare and the Medicaid money, and then figure out how we could do our hospital pricing like Maryland does it, and then I suspect There will still be large businesses in this state that won't want to be in a single payer government plan. And there will be union trusts as well that won't want to be in it, okay, for a variety of reasons. And so we let them opt out as long as they prove they've got a good system based on some quality metric that we all agree upon. And then we set up a public system that's really everybody else. And that's like 2.5 million people when you have all the government folks, the elderly, the folks that were formerly on the Oregon Health Plan, and then people that are working in mid-sized companies or small businesses who would suddenly have access to a large group. I think that's what a single payer system looks like. And then that's our new reality, and then we argue about what level of autism services are covered and all that sort of stuff. And then Eric's group looks more like a provider that we contract with and less like an insurance company.
Did you want to add something here?
Yeah, I mean, I agree with that wholeheartedly. I think the only thing that I would say, and this would be tough for the legislature and for me, but if those private companies get to opt out, I'd say make them follow the same rules that the government program does. Because I think part of the problem is that everybody has their own different authorization rules and what's covered and what's not, what hotels. You get rid of that stuff.
Okay.
That's the problem.
Yeah.
Yes, and actually, that was the piece that I was absolutely gonna chime in with, is we need to provide that parity for competition as well, right? Because it's not fair if one group of, payers has one set of rules and another group has another set of rules, you're not gonna be able to compete on an apples to apples basis. But if those folks who opt out will realize that actually those who have more leverage will be able to control costs and actually provide a really generous benefit, those other folks are not going to want to be on their own. So they won't be able to compete. Exactly. So I'm going to go to the back here. I get to pick.
Yay, oh good. My name is Grayson Dempsey. I'm the Executive Director of Mayoral Pro-Choice Oregon. And I want to thank all of you for your really good work. I think single payer, I think universal Medicare is a huge goal, and I'm grateful to all of you for working on it, especially you, Chair Salinas. Thank you. My question, and really, Mr. Hunter, you got to the heart of this when you were talking about the fear of the administration of ideology governing our healthcare. Of course, I work in reproductive healthcare, and so that's a huge concern for us. Here in Oregon, we had the Reproductive Health Equity Act, of course, made sure that private health insurance companies would cover abortion care and reproductive health care. We reaffirmed last year, after defeating Measure 106, that Medicaid would cover abortion care. We are concerned about the Providence merger with CareOregon, and by mission, Providence not being an organization that covers abortion and certain forms of reproductive health care. And my fear is that in looking at Medicare for all is that we do start to get into a place where ideology gets to govern the healthcare we receive. We know that the Affordable Care Act was a great advance for our country, and yet abortion was negotiated away in that. We know that even in Congresswoman Jayapal's plan that you read earlier, Veteran Affairs and Indian Health Services don't cover abortion care right now because of the Hyde Amendment. And so I wonder how Oregon, knowing that pro-choice values are front and center for our voters and our constituents all over the state, are having conversations about universal health care in a way that makes sure that reproductive health care would never be compromised and abortion access would never go away.
Is that like a comment?
No, it's a
No, it's a
question.
question. I was going to say, and I'm going to go, actually really quickly, I'm going to go back to Glendora's point, which is I think we need people to step up and serve and make sure that those values are being met in our legislature. So I will let everybody else go from there.
It's always going to be political. And it doesn't have to just be abortion. It could be autism, for example. Abortion obviously is clearly front and center, of course, but that's why we have to, even once we get to the, Medicare for all nirvana, it's very obvious that if you don't stay organized, things you have can be taken away. And that's just our political process. There are elections and they have consequences. And so there's always going to be a need for your organization.
I'm not looking for job security.
No, I'm not. But my point is there's always going to be a need for your organization and for your advocacy, and to run people that lift up those values, really, and make sure. That's our system.
Democratic supermajorities.
That helps too.
Yeah, and I think, you specifically referenced CareOregon and Providence. I think, we signed an affiliation agreement, in terms of merger, we're not. I think the idea is CareOregon for 25 years has been doing, I think, amazing work. I'm gonna keep doing it for another 25 or 50. And the problem is the environment has changed on us. You know, we're about the last standalone out there. We don't have the bankrolls and all of our other Medicaid insurance partners in Portland Metro have insurance companies of their own that do Medicaid managed care. So at some point we're obsolete. So we're looking out for ways to say, how do I protect our ability to continue to meet our mission long term, which includes providing all the services we provide right now. And so the only way, you know, that we move forward in this affiliation is if we maintain a couple of really important things to us. One is that we maintain our sort of name, our mission, the way we do our work. I think CareOregon as a brand is important to Oregon, and we want to continue to be. The way we engage our members, we engage our providers to support the safety net, that's who we are. The second thing is that we're secular. You know, we have to be a secular entity because that's, you know, our mission, you know, their mission as well is poor and vulnerable, but ours is, you know, those same folks but from a different lens without any kind of restrictions and so yes, I mean those are the things that are critical to us in these conversations. So the idea is that we remain a secular company and we maintain our name, our mission, our vision. So that's what we're going for.
Thank you. I think we have time for maybe 2 more questions. Go back here and then you'll be over.
Greg Haycock. My understanding is that investment in our infrastructure, whether it's public works or physical infrastructure or social infrastructure, for every dollar spent, it boosts the economy ×4. Now, what you're talking about in terms of cost-effective care, my wife was a nurse midwife, sometimes involves 24-hour shifts, 12-hour shifts, lots of risk-taking on the parts of professionals, and it's about seeing someone for 20 minutes when they should be seen for 40 minutes, and just turning it over and turning it over. So what we're looking at is people being like cogs in a machine, almost like for a teacher, if you got classes at 40 or 30, and you got 5 of them, and they just churn over, and you expect some kind of positive result. What we, I think, need is an investment in the education to produce the more people in that system. And what you're looking at is people having to pay off college loans that were very substantial if you happen to be going to medical school. That has to be reduced. And you could actually create career paths right now in expanding the education. And the more people you put into this business, the more people who are carrying that load, the more people paid a decent rate for doing so, then you create an economy that is growing. What we're talking about now is how do you work in an economy that isn't growing, where it's being sucked out by special interests and by people who are really, you know, setting prices and getting, you know, the cost-effective care is cost-effective for those people at the top and not for the people who are doing the job. So we have standards and we just check off the standards, we type in everything, we're not having any personal contact with everyone, and it's all about the billing. So we've got to take this out. And I think that, you know, I'm sure insurance benefits people, but it also puts us in a system in which that is what we always have to do, which raises the prices and keeps us just mechanically. It's like teachers putting standards on the board so the administrator can come by and see if you're on the lesson that you should be on. But we're entrepreneurial in nature. We like to have personal agency. All of us feel like heroes, but most of us right now are feeling like suckers. So this is not a good situation unless we invest in the education and produce and link up the schooling with sending kids out to the rural areas. Instead of talking about closing rural hospitals because they can't sustain themselves, sending people out to see that people are taking the medicine, see that they haven't fallen out of the bed, all these kind of small things so their kids see, oh, this is kind of interesting. I might like to follow up on that. And just supporting them so they don't have to pay back big loans, but that they are producing service, because we are a service economy. And our medical care system could be a service to the entire world. We could get tourists here to come for Medicare, and we could really sell it. Thank you very much.
Last question.
Hi, I'm Alex Byers. I'm an educator, like Oswego Public Schools. So my one question is about the nitty-gritty of this plan rolls out. I have a lot of social capital. I come from a family of educators, medical professionals. I understand how insurance works sometimes. And it's difficult for me to navigate through the weeds of what I'm covering and what I'm not. And oftentimes, luckily, I have the privilege of being healthy enough that I don't necessarily need to go to the doctor. But when I do need to go, it's difficult to find out where I go. Sometimes I make an appointment online and they're like, oh, we didn't get that appointment. So my question is there funding in this bill that sends for education for people, that lays it out, once we have a new system, lays out the groundwork for someone to access, which is a question of access and accessibility, for people to understand it?
So I was just talking with someone recently about, this is part of the patient-centered primary care model. And right now, that coordination of care, even, because that's what we're talking about, right? Is somebody trying to help you coordinate your own care, doesn't get paid. So if a CCO decided to put that person in, or even like, in fact, just regular insurance, they would not get reimbursed for that. And so that would be eaten up somewhere. That needs to be included. We've talked about this because, and hopefully with a single payer or Medicare for all kind of system, we are not gonna see the complexities that we see now, where people are, having to try to figure out where they go and that sort of thing. I'll let folks on the panel, answer this as well.
Yeah, I would just say that I think you're exactly right. I think that's one of my worries again about sort of a single big system. I think as an insurance company, I would prefer to have less people processing claims and doing appeals and grievances, and more people out in the field or working with providers and care coordinators. And I mean, that's the value we bring to the system. And we do some of that now, but as you said, it comes out of reserves. I mean, we make that investment out of our reserves, thinking that we're going to save money down the road by keeping people healthier. But yeah, I think that's a critical part of any system change, especially this dramatic. So how do we make sure at the end of the day, we don't get so cute about even our vision and taking care of the numbers that we forget the reason we're doing this is to take care of people. And that's at the bottom, that should be the end game. Everything else has to go around that. We're doing it right.
That's where we can pay those insurance companies.
Sure. That's right. All right, well, with that, we are out of time, and I want to thank everyone here on the panel and thank all of you for coming today.